Our next presentation today comes from Rick Anderson. He's the CEO and President of Catasys Inc. Catasys trades under the symbol CATS on the OTCQB. Rick, we can see your screen. You may begin when ready.
Thank you very much, Jim. I'm here to talk to you this morning about Catasys, which is providing a solution to the high cost of substance dependence users in health plans. Health plans have about a $21 billion problem from their high-cost substance dependence users. That's their alcoholics, cocaine, methamphetamine, and opiate addicts. It's more than $21 billion, and that cost is not the cost of treating those individuals, but that's the total medical health care cost associated with those individuals. And as we'll talk about here in a little bit, most of that cost is actually driven by the consequences of substance dependence on the medical side versus on the treatment side. These high-cost substance dependence users, to give it context, is about $111 million in incremental cost per million members in a health plan, which represents about a $2 billion market opportunity for Catasys. Our solution is really to help health plans manage these populations by identifying, engaging, and then utilizing an integrated treatment approach to treat them, and then really tracking outcomes both on a clinical basis and also on a cost basis, because health plans are very focused on saving the cost. And we've had some very good results to date. Based on the people that have been enrolled in our programs, we're showing about a 50% reduction in the total claims by these high-cost substance dependence members in the periods, that's comparing the periods before that they're enrolled in the program to the periods that they've been enrolled, to when they've been enrolled in the actual program. And those cost reductions are being driven by a reduction in hospital days, ambulance usage, ER, that really substance dependence is having an impact. Really cost a health plan on $25,500 medical and also pharmaceutical costs. Diagnosis on average costs a health $2,000 difference between those more annually per million members, or 50% savings that we're showing $1 million per million members about costs. It's one of their primary things in healthcare reform and things of that nature.
Welcome to GoToWebinar, Web Events Made Easy.
Drivers of that, if not one of the most significant drivers in those cost increases, is cost increases related to the delivery of healthcare. So the cost of physician visits, inpatient stays in hospitals, and like types of healthcare, and that's just projected to continue to increase. PricewaterhouseCoopers is projecting that we're going to see a 7.5% increase in 2013, with inpatient costs growing actually at greater than 8%. And the biggest component of what's driving the cost for the membership that we're focused on is these inpatient costs. So we're going to see, or expected to see, increasing costs associated with this population. And health plans are under pressure from their customers as more and more are transitioning to being self-insured and trying to control costs in a variety of different ways. This is the type of program that can address some of these high-cost healthcare spending and help them control costs not only for their own purposes as a health plan, but also for their customer. And then obviously healthcare reform is increasing cost pressures on the health plans and will continue to do so in the future. With 1 million members, a typical health plan will spend approximately $160 million on its substance dependence population in total. So that's both the low cost, or the non-high cost, if you will, population, plus the lower cost population. But 111 million of that is incremental savings that is available, and it's incremental cost spend that's available from the high-cost substance dependence population. So the high-cost substance dependence population is driving the majority of those. So at $17 million per year, we can save a health plan about $50 million over a 3-year term of a contract, assuming it's a 1 million member health plan, of course. And that represents a significant amount of savings for these health plans. Most of our existing contracts today, which I'll talk about in a moment, are 3 years in length. Currently, our clients include Coventry Healthcare and Medicare Advantage through Coventry. We actually have contracted with 3 different Coventry plans in Kansas, Louisiana, and Oklahoma. We've also contracted with Fallon Community Health Plan, which is a health plan in Massachusetts, and Reliant Medical Group, which is a self-insured, if you will, large practice group up in Massachusetts as well. And how does that really compare in terms of where we're going and where we need to go? On the next slide, it really shows the growth potential and Catasys moving towards profitability. We currently have about 500,000 covered members. A little over 100,000 of those were actually added from an operational purpose in the last month. Approximate break-even coverage for us is covering about 1.5 million lives. And in our current sales pipeline, we have health plans that are covering about 11 million lives. And really, when you look towards the short term and achieving profitability and beyond, significant profitability, we have about almost 5 million lives that are currently in contract negotiations and data analysis or post-data analysis. And what that's really talking about is the tail end of our pipeline. When health plans become serious in terms of looking at this as a solution that they may want to implement, they typically want to look at what is their population, how does the numbers that I showed you earlier in terms of the cost of the substance dependence members, what's the prevalence of these members within their health plan, how much money could we potentially save them? They will provide to us their data, we will do an analysis of that. And that represents a significant stepping stone for them in terms of doing this, because that represents a lot of effort and time and cost on their part to do that. The total potential market, there's about 191 million covered lives in the United States. So, for the number that we're talking about in terms of 11 million in the pipeline and almost 5 at the tail end of that pipeline, it's obviously a very small portion of that. So continues to be significant upside growth to that. Catasys really is a different entity that does not have any direct competition. Currently, substance dependence benefits for health plans and self-insured employers are typically managed by managed behavioral health care organizations under fixed fee contracts. Their primary driver under those contracts, because they receive a fixed amount of revenue up front, is to minimize the costs associated with providing treatment, and substance dependence is just one portion actually of what they do, because they'll manage the entire behavioral health benefit. As a result of that, the system's passive. So most of the high-cost substance dependence users are not identified. About 74% of the members that we identify and go after do not have a behavioral health claim in the last 12 months. So they're not actually going through the behavioral health system. The managed behavioral health care organizations are focused on what they're paid to be focused on, which is managing that overall behavioral cost and utilization, because when members get treated in their system, it costs them money. They have to pay the providers to provide that, and that cuts into what their profitability is. So they focus very much so on managing and reducing those costs. As a result, there's underdiagnosis and undertreatment is rewarded. The treatment that is provided tends to be fractionated and inconsistent in delivery, and so there's really not a focus on the high-cost medical expenses. They're focused on the behavioral. And as I mentioned earlier, the vast majority of the costs associated with the population we're going after really relate to medical issues, not behavioral. So how are we changing that? We're changing the paradigm in large part because we're actually seeking out these individuals. So we do a claims-based identification and segmentation for our customers. We then do a continual outreach to these individuals and engagement. So once we've identified the individuals, we're able to actually go out and engage members that otherwise would fall through the cracks, if you will, and not be dealt with in the existing system, and they're dealt with within our system. We bring those people in. We have, if you will, a unified provider to address the fractionated delivery system. So we're using standardized approaches across our entire treatment spectrum, and I'll talk about how we do that in a minute. We train our network of providers that we create. We monitor the delivery of care ourselves through a variety of different methods. One of those methods is, and it also helps all of our providers communicate, is that we actually have a substance dependence electronic clinical system, which is a web-based system where the medical providers, the psychosocial providers, and our care coaches can all communicate across that platform and see how a member is doing, and it also allows our medical staff to review how members are progressing, what treatment has been done with those members, and potentially bring people that are non-compliant into compliance and make sure that the care that we're looking for is consistent and it's standardized and delivered in the way that we're looking for. And then within the care paradigm itself, we actually have a year-long program, which is essentially unheard of in the field. So our care coaches stay with a member from the first day that they enroll in the program, if not before, all the way through 52 weeks when they graduate from our programs. We use some patented treatment protocols. We make sure that there's a continuity of treatment. Our care coaches have a very high-touch support associated with this. They may have more than 110 touches with a member across a period of time, and frequently, even for members that graduate, our care coaches continue to touch base with those individuals, although on a much less intense basis. And one of the things that we focus on, which is not the case generally speaking in the treatment community, is translating the latest science and the evidence-based practices and making sure that we're getting those in a practical way into clinical practice. The next slide is really an overview of our program from a treatment perspective. So as you can see on the far left side, we do continual engagement and outreach until we're able to enroll a member. Then your typical member would be referred to one of our medical providers. The medical providers and the psychosocial providers on this diagram here are actually people that we contract with to provide our care, that we contract directly with. So for a health plan, we create a sub-network, if you will, of their existing providers because we need a much smaller specialty network. We identify all those people that would be appropriate within a health plan's network. We pick those that we think will work best within our system. We contract directly with them. So then those medical providers do a medical evaluation and assessment of the member. They're looking for a couple of things, one of which is they're looking for any medical comorbidities that have not been identified, or medical comorbidities like diabetes or asthma that have been identified, and making sure that there's a treatment paradigm in place for those individuals for any of those disease conditions. And then they're also looking to see whether there's any medications that would be appropriate to put the individual on that would either help with the cravings that they may have for the substance that they use, alcohol, stimulants, etc., and or would help the member maintain abstinence once that they've stopped using. Once they go to a medical provider, then they will go to our psychosocial providers that provide our proprietary on-track relapse prevention program, which was developed in coordination with a center that's established and works with the federal government on these issues in terms of psychosocial treatment. It's primarily cognitive behavioral and motivational enhancement therapy designed to teach members the knowledge, skills, and confidence in order to be able to apply the learnings that they have and stay sober and continue that sobriety. And then, as I mentioned a minute ago, our care coaches stay with these individuals for an entire 52 weeks. They do everything at the beginning, from scheduling appointments, reminding appointments, arranging transportation, assisting members, helping them out, understanding what the homework is that they're working on from, like, let's say, the psychosocial. They may help coordinate care from not only from our care perspective, but if they don't have a primary care physician or they need a specialist in a certain area because of some other disease that they have or chronic condition that they have, make sure that that's in place and coordinate with those people as well to make sure that there's a coordinated treatment team. Because we are focused on and held responsible for the total cost of these members, we're very focused on making sure that the overall cost for these members comes down. One of the other advantages that we have for having a care coach involved in this process is your typical treatment paradigm would include, maybe up to 12 weeks of treatment for an individual. Frequently, it's substantially less of that, and then the member is essentially sent out on their own. Hopefully, they'll attend something that would provide them some support, like AA or something along those lines. In our case, though, the care coach, who all of our care coaches are RNs and LVNs, so nurses with substance dependence and mental health backgrounds, they stay with that member for 52 weeks. So as a member progresses and they have stressors, like at this time of year with the holidays coming up, family-based things create a lot of stressors for this population. They can identify that. They can understand if a member is progressing towards an issue that may lead to a relapse or a significant lapse, if you will, which in the past, in these people's case, would lead to them not taking care of themselves, not taking care of their other issues. So let's take, for example, an alcoholic diabetic. This individual, normally with a diabetic, they will be trying to manage their diabetes, measuring their blood sugar levels, taking insulin if that's required, hopefully eating better, trying to get exercise, things of that nature. For a population that's substance dependent and diabetic, typically they're not eating well, they're drinking, let's say, instead of eating, which drives the blood sugars crazy, which starts to have diabetic symptoms. And then the worst part about it is they'll typically tend to drink more and ignore those symptoms until such point as those symptoms are so bad that they end up in an ambulance, in the ER, and admitted to the hospital. And the data shows once they are admitted to the hospital, they tend to stay twice as long as somebody who's not substance dependent with the same diagnosis. So what that care coach helps is it helps break that cycle and intervene earlier if there tends to be things that look like we're going down a pathway of a significant lapse that could result in complications related to in this case, for example, diabetes. So one of the key factors really is patient identification and engagement. The current system, as I said, is passive. It really sits there, and when somebody seeks treatment, they're able to receive it, generally speaking, although there are barriers to that. 74% of the substance dependence members that we're going after have no behavioral health claims in the last 12 months. So that means that the vast majority are untreated. They're being diagnosed, for example, in the hospital. They're given a referral that they never follow up on. We actually have a unique and a proprietary data analytics and screening methodology that allows us to identify these individuals that are costing the health plan a great deal of money and have a substance dependence diagnosis. And then we do outreach within our programs, and as you can imagine, there's a lot of experience and knowledge that goes into approaching these members and being able to bring them into a treatment program like this. And we've demonstrated that we have the success in being able to convince these high-cost substance dependence members to enroll in our program. And then just a little bit more in terms of the integrated aspect of our treatment. We combine the medical treatment with the cognitive behavioral and motivational relapse prevention therapies. So we have both a medical approach and a behavioral approach, which is very rare actually in the program, and then we combine that with the 52-week program. And having all of that coordinated and having those the different members of the care support team be able to work together, especially through our web-based clinical system, really allows the whole treatment team to be able to deal with the individual and any issues that are coming up. So when the psychologist sees them, they know what the last medical visit was that the member had, that they were having trouble, for example, with their cravings, and that the MD has adjusted the medications, and they know what the last assessment is that the care coach gave the individual, so they can hit the ground running and actually address those issues with the member, and we don't have the fractionated care that you have in the normal system. So looking at what our enrollment is, most of our new customer launches that I mentioned in terms of the customers that we currently have launched between the second quarter of 2011 and the fourth quarter of 2012. As I mentioned a little bit ago, we added a little bit north of 100,000 lives in November actually of this year. We've seen a greater than 400% increase in enrollment from the second and third quarter of 2011 to the comparable period, second and third quarter of 2012. I chose those quarters because that's relevant to when we launched the program. So you're seeing an increase due to both new programs coming on as well as an increase in enrollment in the existing programs, and we anticipate that our near-term growth opportunity for our enrolled members will be both the recently added population that we have as well as continuing increases in enrollment in our existing plan, and then customers in the late stages of the pipeline, the almost 5 million members that are late stages of the pipeline. I don't expect all of those to come on obviously in the next quarter, but as those come on, that provides a significant opportunity for growth as well in our enrollment. And really here's where the rubber meets the road. The program performance is ultimately what matters, not both in a clinical perspective, because you have to get the clinical results to get the reduction in the costs. Our customers, their primary focus is, can we help them address this population and can we help them reduce their costs? So far for the members that we have enrolled extremely high for this type of population, we primarily credit that with the high touch. of our care coaches and the other care members that we have. And as I said before, the members are exhibiting these decreasing costs based on an inpatient utilization decline of greater than 50% and an ER utilization decline greater than 50%. And that's where the vast majority of the costs are locked up. So the reduction in those would flow along with the reduction in the total healthcare costs for these members. So how does our business model work as it relates to this? We contract directly with the health plans to provide this service to their members. We enroll the members directly. As I said, we do our outreach and engagement. We also work with the health plans, any existing programs that they have, wellness programs, case management programs. Several health plans will have discharge planners, or they work with discharge planners in the hospital. So we also work through that side of it, although the vast majority of our enrollment comes directly through our own efforts. We charge the health plan generally monthly fees for enrolled members. In some cases, we actually charge an upfront case rate, and then we share in a savings from the program. So the case rate would be lower than what the 12-month of monthly fees would be, but we have the opportunity for upside in the fact that we share in those. And then, as I said before, we contract with medical and psychosocial providers to provide the services in the market directly, the medical and psychosocial. Almost all of the other services are provided telephonically, although we do tend to have 1 to 2 of our employees in a given market so that they can interact with the members directly, go to the hospitals, things of that nature as required. So here's what our revenue model looks like, and this is really an example based on a million member health plan, and there's a difference, as you can see here, whether the population is commercial or a Medicare population. With Medicare Advantage, and we currently have a contract in Medicare Advantage for Coventry in Kansas. All of our other contracts are commercial members. So if you look at, what is the incidence rate of substance dependence, and this means people who got a substance, matter of fact, those who have substance dependence would be much higher. It is an under-identified, underdiagnosed disease, but you can see about 1.9 to 2.6% of members in a commercial and Medicare population will get a substance dependence diagnosis in any given year. Of those, the high-cost members, these are the ones that we go after, range between about 0.5% to 1.24%. So, 5,000 to 12,000 members, depending on the type of population that you're talking about. Assuming a 20% enrollment rate in our program, that's between 1,000 and almost 2,500 people enrolled. And the revenue per enrolled member, this would be the fee that we charge if we charge on a monthly basis, is between $8,500 and $9,300. So as you can see, that generates revenue for Catasys of between $8.5 million and $23 million per million members. Now, Medicare populations tend to obviously be smaller than commercial populations tend to be, but this is just to give you context associated with that. And of course, our fee is the expense to the health plan. So taking a look at, what is really the return associated to the payer or the health plan, based again on the million-member health plan. The average cost of these members is about $25,500. We're projecting our average savings factor of about 50%, which is the savings, about the savings that we've achieved to date, a little bit less actually. So your projected savings per member on total healthcare costs is about $12,750. On that same 1,000 commercial members enrolled, we'll save about $25.6 million over a 2-year savings period for those members. The total cost is about $8.5 million from the last slide, so the projected ROI is about 2 to 1 on this population. And $25 million represents a significant amount of savings for a million-member health plan. One of the things about Catasys that's very interesting as we continue to grow our lives and looking at our pipeline is the overhead structure is relatively fixed. Our current overhead structure is sufficient for 3 million or more insured lives, and for context, $1.5 million is break even, and we currently have about $500,000 there. So most of the costs associated with our delivering care is variable and driven by the members that are in treatment. So we add members, network payments to the people that are providing payments. all happen as members are treated. So all of that's associated with a variable cost. The overhead structure does not change a lot, so we get a lot of leverage on that. Our current monthly operating burn is about $450,000 and coming down as we continue to increase our enrollment. As I said, our operating costs are essentially variable. And the fixed cost and overhead increases once we get past that 3 million members are generally going to be relatively small, because you have to have the systems in place, the data analytics, a number of these kinds of things that drive the majority of those costs in the overhead have to be in place to service health plans at all. As you start to grow, you get a lot of leverage on that. The additions to that are relatively minimal associated with that. So in summary, substance dependence is about a $21 billion a year problem for health plans, about a $2 billion market opportunity for Catasys. We are the only currently targeted solution that is demonstrating better outcomes and lower costs associated with lower inpatient admissions. We have a variety of things that are patented in proprietary technology and analytics, primarily around one of the key factors here, which is the ability to identify, outreach to, and engage these members. And then a lot of the treatment paradigms that we utilize are based on knowledge that we develop internally based on the outcomes that we're seeing from the data that we're collecting. We're demonstrating a greater than 50% cost reduction for health plans, which is really the greatest indicator in our minds for the future in terms of being able to bring on additional plans. And for those additional plans, we have a substantial pipeline and the potential for rapid growth associated with that, especially given the number of health plans that are in the final stages of our pipeline. And that concludes the presentation for today.
Rick, thank you again. I just want to say thank you for taking the time to present the Redshift Small Cap Virtual Conference today. We will go ahead and jump into Q&A here. Now, I know this was covered during the presentation, but if you could cover it again, it'd be appreciated. How does Catasys market to substance abusers specifically?
The program that we have when we do outreach to the individuals, as I said, is really through two different main channels. One is our own direct outreach, and the other is through the health plans. For our own direct outreach, it depends a little bit, but primarily the standard program would be that a member who was identified will receive a letter once a month. Every month it'll have a different theme. It'll relate to things that the members can relate to, and they don't necessarily talk about substance dependence or don't talk about substance dependence directly. And then members receive up to 3 phone calls a month subsequent to receiving that letter. That's the primary outreach approach that we utilize. We also will visit members that are identified while they are in the hospital. A lot of our members, the cost associated with this is driven by inpatient medical admissions. To the extent that we can catch them while they're in the hospitals, we'll visit them in the hospitals. And then also we utilize the health plans approaches, as I said. So their case managers, their discharge planners, any wellness programs that they have, if they identify and have somebody, let's say in their diabetic program, that they probably can't get a hold of, but they do get a hold of them, they can refer them into our program as well. So those are the primary ways that we outreach and engage the individuals in the program.
Thank you, Rick. Next question here. What is the total headcount of care coaches as of the current quarter for Q12?
In the fourth quarter, we currently have about 6 care coaches. And 6 care coaches and outreach staff that are dealing with the member population.
Thank you, Rick. Next question here. Of those that Catalyst markets to, what percentage of substance abusers typically adopt the Catasys program?
We have a targeted enrollment of about 20%, and we achieve that enrollment. It takes us from the time we launch the program until that we achieve, if you will, steady state enrollment. It takes about 12 months to get there, so they tend to start a little slower and then have an increase if you think about it like advertising, reach, and frequency, as well as these members tend to have recurring incidents that happen to them, which are catalysts for them entering into a program, and more of those will have those kinds of...
Welcome to GoToWeb. Web events
recently finalized
target to achieve those kinds of
is
rates.
the final stage of
muted.
Thank you, Rick. Next question here. Of the members you enroll, how many of them are high utilizers of drugs?
I'm sorry, Jim, I didn't get that.
My apologies. Of the members that Catasys enrolls, how many of them are high utilizers of drugs or alcohol?
All of the ones that we are enrolling are high cost, and as a result of that are generally on the higher end, if you will, of the substance dependent scale in terms of use at the time that they enroll in the program, if that answers the question.
I believe so. Next question here. How long has Catasys been developing the proprietary data analytics and screening solution?
We started developing these in 2010. So we have 2.5, almost 3 years of development.
Thank you, Rick. Next question here. What are some of the major differences between a program like yours and, say, Alcoholics Anonymous?
Alcoholics Anonymous is a self-help group that is, when members are looking for assistance and support associated with staying sober, it can be an extremely powerful tool. As a matter of fact, it's one of the things that if the members are willing to engage in, that we'll recommend that they do engage in. They do not, seek out and find individuals to come in, which is a major difference between what we do in any treatment program, is that we're actually identifying and outreaching to these individuals in order to bring them into a program. The other aspect of our programs that are different is we use a very integrated approach. We utilize all of the latest science that's out there, and we integrate both the medical and behavioral. The medical aspects have a very strong indication, not just in terms of pharmaceuticals that can be prescribed to help people stay sober and address cravings, because one of the key factors really for a lot of members that are craving when they first quit using substances is that if you can address and help lower their anxiety, their depression, and their cravings associated with that quitting, then you can keep them stable and keep them in the program, and then you allow the psychosocial aspects to have an impact. And the psychosocial, the motivational enhancement therapies, the cognitive behavioral therapies, those address the members, the issues that they have, teach them knowledge, skills, and confidence to be able to stay sober on a go-forward basis. So most other programs don't have that integration. They don't have all of those pieces associated with it, and they're not, most programs now, Alcoholics Anonymous will continue for as long as you want to participate in the program, years and years, and is a great support network for that. And as a matter of fact, is one of the things we do at the end of our 52-week program is that we make sure in the last few months that members have developed a support network. In some cases that will be Alcoholics Anonymous. In other cases it's friends and family. It may be their church group. It could be anything that provides them the structure and the support to help maintain their sobriety. Those are the major differences. And treatment programs in general will be short in nature if you're talking about either inpatient detox or intensive outpatient treatment or even psychologist visits. They're most of the time they'll be 3 months or less. We provide not only that psychosocial but the medical, which they generally won't have, and then 52 weeks worth of care coaching, and all of that's on top of what we do for the health plan, which is identify and enroll these members for them.
Thank you, Rick. Next question here. How many state health care plan providers has Catasys signed on as of Q4, and are there new ones coming on board?
If that question relates to customers that we've signed up, we currently have approximately 5 customers that we have signed agreements with, and we've got in the 5 million covered members in the tail end of the pipeline, there's another half a dozen or so health plans that are in that number.
Okay, Rick, next question here. Do you charge members directly or the healthcare plans?
No, our fees come directly from the health plans. So we contract with the health plans pay us to provide services to their members. And in most cases, For commercial populations, there is no copays or coinsurance associated with this, so it's very low or no out-of-pocket costs for the members.
Thank you, Rick. I believe that will conclude the Q&A for today's presentation. And again, like I say, thank you for taking the time to present at the Redshift Small Cap Virtual Conference.
Thank you for the opportunity.
That was Rick Anderson. He's the CEO and President of Catasys Inc. Catasys trades under the symbol CATS on the OTCQB.